Today I want to talk about growth, right? So, somebody just joined in. Turn your camera off there. I see a ceiling. So just go to the lower left-hand corner and turn off your camera. There you are. Thank you. So, just because when you have your camera, then you pop up on my screen, it makes the other one smaller. So, all right. So today I want to talk about growth. This is the last chapter in Unit 1. Is about bacterial growth. And if we have time at the end, we can talk a little bit about oxygen requirements and temperature requirements and these kind of things. But what I don't want to do with our limited time together is just focus on stuff that you can clearly get through the videos. Like the oxygen requirement of microbes, very, very important, which is why I did a detailed video where I covered every single thing you need to know. So, no, I'm not hearing anything. So if you're worried about any extraneous sounds, I'm not hearing anything come from anywhere. So right now it's good. It's actually a setting. We had it set up where when you join, no matter what you try to do, it should have already had you muted. So everything's great. Everything's great right now. All right, but I want to talk about, so if we're talking about growth, why does growth matter? Like, why do we care what temperature microbes grow at and what oxygen requirements they have? Well, that's important stuff, which is why it's covered in the videos. But I want to talk more about the relationship we have with microbes and how we influence which microbes grow in, on, and around us and which ones don't. So I want to go back to the beginning, and I want to start by having this discussion. And I'm asking for your guys' feedback. You can start typing in right now if you want. What are things that we do or don't do, or feel free to share here in Sioux City and I'll share with everybody. What are things we do or don't do that influence the microbes that go in, on, or around us? So how does your microbiome, how does you as an ecosystem, right? This whole idea of I contain multitudes, right? This idea that you're not a human, that you're from a cell standpoint, you're half human. From a genetic standpoint, you're like 1% human tops. So how does this relationship with microbes look so different than it does before? And I'm not saying all good or bad. There are things we do now that are great, things we do now that are terrible, but they both, there are pluses and minuses. So I'll just kind of plot through it, and I want to, I like to talk about difficult things. I like to feel like my class is a place where we can bring up stuff and have real discussions about stuff, and the implications of it. So, like today, we're gonna. This is where it gets difficult when we're talking about what should we do, right? How do we preserve the curative properties of antibiotics? How do we save children? Because that's really what matters, right? If we talk about, because I'm going to talk about things like, should we just be, blanketly treating every mom that's positive for Group B strep with antibiotics? I'm not saying not to. Just like the question of should we be putting antibiotics in the eyes of all 4 million births in the United States every year? Well, both of those situations, and Group B strep is definitely in a whole different sphere than the worried about gonorrheal infections in the eyes, because you're looking at much different numbers, and absolutely using antibiotics saves some of these kids' lives. But the type of things I want to pose to you today is, let's say, we'll start back at the vaginal birth versus cesarean section. So, sadly, we're going to be talking about your mother's birth canal today, so that's always a great discussion, right? But we're going to go all the way back to where you were first seeded with microbes, and then we're going to work all the way up through. We'll see how far we get today. But we have to look at microbes through a different lens. We have to look at the use of antibiotics through a different lens because of that idea last week we talked about with the whole the idea of this counter dropping to zero. So when we made the decision to treat, I think they use streptomycin. There's streptomycin and erythromycin in the baby's eyes after they're born. Erythromycin, thank you. So when we made the decision, and that makes sense because of the gram-positive organs we're worried about. But so when we made the decision to give all babies these antibiotics to protect 200 kids, so if we didn't do that at all, so I'm not saying not to do it either, but if we didn't do that, if we didn't put antibiotics in the eyes of these kids, now any of these discussions could take a half hour because number one, there are options that aren't antibiotics we can use. We used to use silver nitrate. Number two, if we do this, if we dose 4 million kids with antibiotics in their eyes, 200 kids won't go blind because of gonorrhea. The gonorrheal infections that were passed into their eyes from their mother. But that's 4 million doses of antibiotics. So if we're talking about protecting 200 children, which is awesome, I want every kid to have a shot at survival. I never want to see a kid get sick or go blind or die. But 4 million doses of antibiotics. When erythromycin quits working, and we all have to understand that it will, right? It's a matter of when, not if. When erythromycin quits working, how many kids are going to die? Right? These are the tough discussions we have to have about this blatant. Because when we made the decision to treat every Group B strep positive mom with antibiotics, which there were multiple paths we could choose. I'll send you guys a link. I don't think I sent it to you last night because we hadn't had the discussion yet. To this evidence-based birthing site that just goes through the whole Group B strep thing. It's awesome. And I am not anti what we're doing. We would have to be clear about the fact that hopefully there are better ways. And I think that better diagnostics is the key. But if we just have to look at this through a different lens. So are there smarter ways to do things? Like with the whole gonorrhea thing. We can find out if mom has gonorrhea pretty easily. So faster diagnostics and being smarter about these things. But why did we do this? Why did we decide, some kids are at risk with Group B strep. Some kids are at risk for gonorrhea. Let's treat all moms and all kids with antibiotics. When we did that, there wasn't a downside to antibiotics. And so now we practice medicine the way that we practice medicine, but we live in a world where we now understand that it isn't all positives. That was the 20th century thinking was, let's just coat the world in antibiotics because there's no downside. We're killing microbes, we're saving lives, which we're doing, but we now have to understand, we have to live with the fact that this indiscriminate use of antibiotics. At one point in the 50s, there were 26,000 over-the-counter products that had antibiotics right in them. So now at least we're smart enough in the U.S. anyway to prescribe antibiotics, but we can talk about the food supply as well because that's getting smarter too. But there's always going to be another side to the story. We'll go through all these things today, but I just want you to. So I'm not trying to offend you when I bring up the fact that maybe those 200 kids going blind, and it's always a bad thing when 200 kids go blind. But we have to look at this from a different standpoint, and that is that what if we're wasting antibiotics that in the future would keep kids alive rather than keep them from going blind. So there's a happy medium. Let's find out if mom has gonorrhea and only treat those. So I'm just going to kind of play devil's advocate with myself. I just want to warn you that we may have to have some uncomfortable conversations because when we talk about antibiotics in the food supply, especially in the Midwest, it is blasphemy to talk about the food system in the Midwest. In the United States and the Midwest, it's blasphemy to say that what we're doing with food is wrong. But if 50 years from now kids are dying because we saved kids from going blind today, that's one thing. If 50 years from now kids are dying because we wanted cheaper pork, that's a whole other thing. So let's have these uncomfortable discussions. I have no idea where today's going to go. That's why I keep looking at this chat feature and I want to hear from you guys. But I'm going to start at the beginning. So hopefully you guys know we've already had a couple of TED Talks that have broached the idea that the delivery method matters. So whether you were born vaginally or via C-section does have a demonstrable impact on your health. So we don't know the numbers, right? We don't know, like when you decide if you're going to have a C-section or not, we don't know if it's your odds of having allergies goes up 7% and your odds of having asthma go up 6.5%. We don't know these numbers, but based on all the evidence, if you're born via C-section, there's a list of things that we can show. More likely to have allergies, more likely to have eczema, more likely to have asthma, more likely to have autoimmune diseases, more likely to be obese, and more likely to die by the age of 62. So I can't tell you numbers. These are the trends we see. So, and of course, everyone's got the exception to the rule. Like we talked a little bit before about this hygiene hypothesis, whereas kids that go to daycare and have siblings and live on farms are less likely to have allergies and asthma and autoimmune diseases. Then someone pops their hand up. I know someone with siblings who lives on a farm and went to daycare and has asthma. Yeah, I'm talking about population-wide, increasing or decreasing probabilities. So, my stepdaughter who's 18, my wife's first baby. So like you try to create this sterile world. My wife took. We were just having a discussion yesterday. My wife. She took their own high chair to restaurants. When they went to the grocery store, she would sterilize the cart and put a liner in the cart. Like my stepdaughter's butt never touched a grocery store cart, I guess. She has the worst allergies I've ever seen a human being have. She's getting desensitization shots. She's taking multiple medications. It's just a nightmare. It has a huge impact on her life. That's one case and that's one kid, right? And because I would argue, so I could use her. I could use my stepdaughter and say, see, we're supposed to be exposed to a lot of microbes. And I think we are. But you can find people that played in the dirt every day and had siblings and went to daycare that have allergies as bad as her. So we are really careful not to look at that one person and say, well, yeah, I had... And I see it all the time when we have these discussions, especially in the thread discussions. You've got like, oh yeah, so I had a kid that was born vaginally and they're super healthy, and I had a kid that born C-section that's not. There's so many confounding variables here. But statistically speaking, it is better to come out of mom's birth canal. And I think when in doubt, just biology, right? Evolution's a pretty cool thing. Adapting to your environment's a pretty cool thing. So the vagina, the microbiome of the vagina is different during the third trimester of pregnancy than at any other time in a woman's life. And that goes to all mammals. And it's clearly like it's designed to be what seeds the babies. So now does this mean I'm saying no C-sections? If you need a C-section, it's like, well, too bad, because no, absolutely not. But I do think there are countries where almost hovering between 40 and 50% of births are C-sections now. That is scheduling, that's cosmetic, that is not medical. Like when I look at what we need to do medically, I like to look at like the Scandinavian countries. About 4% of births there are going to be C-section. So we have a range between 4%, I think it's like in that 7 or 8% range in the US, it changes a little bit every year, and then it's almost 50% in some countries. So am I advocating that no one's born via C-section? Absolutely not. But when we look at this information, I think that C-sections should be put in their place and they should be used in emergencies. Anyone have any thoughts about that? Anyone here or want to type anything in the chat about that? Just this idea of, there's a baseball player, probably time flies, might have been 5 years ago. A professional baseball player, he missed the first couple games of the season because his wife went into labor and had a baby. And there were people mad at him that basically said, she should have had a C-section. You need to get back here to play this game, right? So when people that think that way don't think it's a big deal to not be born through the birth canal. Because if that player would have made that decision, and this is, again, there's never any condemnation with me. If you had a C-section, I don't care. But this idea, right, that it's just no big deal to have a C-section, we have to get past that. Just like it's no big deal for a doctor to prescribe antibiotics for a viral infection and just say, well, it's just in case you get a secondary infection. These things are a big deal. So that's where this starts, right? All right, so I'm seeing some good things in here. So then, when do the doctors get held accountable for these children that have health issues? What would you consider an emergency? These are great questions, right? So, if the baby's life is at risk, or mom's life is at risk, or both, then the C-section is a complete no-brainer. Just like this idea where I don't want to go back to a time, if you go back to the 1880s in the United States, we had the same problems with our water and our food that other countries do now. We're not immune to this stuff. In the 1930s and 40s, malaria was a problem in the United States. Like, we've conquered these things. And we've made a lot of progress, but now you can make the argument that this is where, there's a really good book if you're interested in this called Survival of the Sickest, right? The fact that we traded clean drinking water, not having malaria, our kids not dying of typhus. We traded that for increased allergies and autoimmune diseases. Well, that's an awesome trade-off, and I have autoimmune diseases. I would much rather my son develop psoriasis than die of typhoid fever. So again, I think that this is where. And then where we draw that line, what constitutes an emergency is going to be different for every, for the doctors involved. But just generally speaking, let's just put it this way: you should have to justify why doing a C-section. I think, and I don't know if we're here yet. 5 or 10 years from now, you're going to hear more and more about this. But I think we should reach that point. So a question: shouldn't the doctor know that? I don't know. I never. Maybe you guys trust doctors, but and I do. I do to some extent. But to trust that they know things outside of their sphere, you have to understand that medical school is specialties. The whole point of having specialties is that you know everything about something, right? But the problem is that the obstetricians, OBGYN people, they understand the microbiome more than a lot of other specialties because of vaginal dysbiosis and all those kind of things that can come with it. But just to think that they're keeping up on the literature in a time where, in a time with managed care where they're seeing patients and they can't even keep up with their own specialty, to think that they've been keeping up. I have the luxury of getting paid for about half of my job just to learn cool stuff so I can share more stuff with you guys. They don't have that luxury. So that is tricky. But these are all excellent thoughts you guys are bringing up. So, but the whole accountability thing, that's a real tricky one. That's, part of that we'll bring that up again later when it comes to things like strep and the use of antibiotics, because there are conditions where we know not everyone needs treated with antibiotics, and not everyone needs treated with antibiotics now. But if you're the one that says that, if you're the one that says your strep looks like the kind of strep that won't need antibiotics, or I'm a big fan, I think in the future we're going to see post-dated antibiotics. You go to the doctor, and if you're still sick in 2 days, take this prescription to the pharmacy. But who are going to be the first doctors to do that? Because the whole idea, my wife works in oncology, and not all doctors got A's. I always like to say, that's funny. I always like to say, not everyone, somebody had to finish last in medical school, right? You need to have that opinion we trust doctors in areas where they're not specialists at all. Like we have this discussion in nutrition all the time. It's like you have 4 hours of nutrition training, if that. Please don't tell people that multivitamins are bad for them, and don't tell people that the diet that they're using is a terrible idea. You haven't the slightest idea unless you're self-taught. But so back to what I was saying, this idea that so I like to put it this way: doctors practice medicine like there's a lawyer looking over their shoulder. So my wife works in oncology. So when you look at the clinical trials that are done, all these new treatments and these kind of things, they're only done on people. They're done on the worst of the worst patients. They're done on people that have already failed other treatments. Because, like my wife works with a team of geneticists right now. There's like a dozen geneticists at her clinic. And they look at the tumor at the genetic level and try to determine what treatments would be best for that tumor with that genetic sequence. But if you have pancreatic cancer, the standard of care says this is the right way to go. If you deviate from that and the patient gets worse or dies, I keep bringing this standard of care because when they sue you for malpractice and they have another doctor sit in the I don't know where you sit in the court, where they're getting what doesn't matter. You know what I'm talking about. On the TV shows, they're sitting up here and the attorney's talking to them. So all they got to say is, how should people with pancreatic cancer be treated? And they'd say, well, you do this. Well, they didn't do this because they tried a new treatment based on this genetic stuff, or they tried a treatment they thought would be more effective, or maybe they believe in more of metabolic theories of cancer, and they decided to try things like this whole press pulse thing, where they tried dietary interventions and stuff like that. Well, that's malpractice. So how does medicine ever improve? Because with clinical trials, you're only getting the worst of the worst. You basically have to fail standard of care treatment before they can put you in a clinical trial. So do we truly know how well these drugs work? We only know how well they work on people that are already damaged by chemo and radiation and already failed the treatments that are supposed to be the best. So, but this is the problem with standard of care. Same thing here. If I told you that only 5% of people that have strep throat need antibiotics, but we don't know which 5%, and you're a doctor, what are you going to do? Are you going to give everyone that has strep throat antibiotics to protect yourself, or are you going to say, let's wait it out a few days and this and that, and that might be the right thing to do for us as a society. But if all it takes is one person that dies or gets heart damage because their strep wasn't treated properly, and you're done, your career's over. So these are super super tricky things. So if you've got So doctors are much more, especially if you're a surgeon, you're concerned about a positive result is didn't die on the table, right? And they're still alive a couple weeks later. So do you think the person deciding whether you need to come out through your mom's belly or birth canal could care less? They could care less about if you're going to be an asthmatic when you're 25. They're getting you out of your mom alive. So, and I don't fault them for that. But this is what I'm saying. We need an entire shift in how we see these things. And I hope that you guys are the tip of the spear, because you're going to leave this class with an understanding of our relationship with microbes that I'm assuming your doctor doesn't have. And I'm assuming the person that delivers your children doesn't even have. So, all right. So C-section for emergencies, like we were saying, I think convenience is the point. Like I'm not no condemnation, but if you read anyways about people that have C-sections because they they think about things like C-sections by what their vagina is going to go through, or where they might have scars, or these kind of things, or scheduling. Truly, that's a big issue. So, and in the past, when we never saw the cons, when it seemed to be all pros, just like in 1980, they'd give you antibiotics for a viral infection because all they saw was we might be preventing a secondary infection. No one saw that we were destroying the curative powers of antibiotics and hurting the patient over the long term. So this is good. This is exactly what what I want to see is that we need to take these things more seriously. Just like we talked about the appendix a little bit, we'll talk about a little bit more. The idea that a generation ago, if they were near the appendix, they would cut it out. And there still might be some doctors that do that, which is why they say science and medicine progress one funeral at a time. But most doctors are going to take the appendix out when it needs to come out. And I'm not advocating for keeping it if it's going to burst, and if it bursts, you got a 50-50 chance of survival. Get the thing out if you have appendicitis. But the idea that this organ does nothing is bygone. And if you don't understand that, it's 12 years ago they knew this. So if you go ask your doctor, hey, what's the appendix do? And they say nothing, that just shows you how far behind they are. But I'm not really blaming them. There's just too much knowledge. About 1 million new studies are published to PubMed every month. So find the best doctors you can that are keeping up to the best of their ability. But don't blame your doctor that they can't read 1 million studies a month either. So, all right, any other thoughts on this? Let's see. Doctors aim to please. That's something too with antibiotics. Absolutely. The idea of the doctor that takes a stand and says, I'm done with this. The doctor that says the microbiome is so important. I'm done with kowtowing to patients. I'm done with worrying about that lawyer looking over my shoulder. Well, they're like you said their patient satisfaction scores are going to be low, and then their bosses are going to wonder why that is. Instructors get let go at Western Iowa Tech if they don't pass enough students. So sooner or later, you got to decide now: are you not passing enough students because you're a bad teacher? That could be part of it. But if a large chunk of your students are failing, and you're thinking my head's on the chopping block, what do? You start satisfying your students. Well, it's the same thing with if I'm in a business which is what medicine is, a business, whether you want to think of it as or not, the number of people that come to see me affects how much my income. Then patient satisfaction does matter. So it just giving in at this point and just saying I'm just going to do more C-sections. You'll make more money. Your patients will be more satisfied. Maybe you're going to have less short-term negative implications. You're less likely to get sued. And I get why you take that path. So we need to change how we view things. It's kind of like the idea of the food system, which we'll get to. Because by volume, 80% of the antibiotics that are used are put in our food supply. They get to us indirectly. But I would never blame a farmer for that. If I'm a farmer, my job is to feed my family. So we need to change the system. So the system is what needs to change. So I think we're seeing that. In many countries, anyways, we're seeing C-section rates drop. They'll never be zero. And not that the Scandinavian countries do things perfectly, but just so you know, I really look at them as a model. Now they're a small country. They're small countries. They're homogenous. They might be able to get away with things that we don't. But when you look at things their C-section rates are half of what are in the U.S. and a tenth of what are in some countries. Their antibiotic use, the average kid in Finland or Norway is going to get a quarter of the antibiotics that your kids are getting. And you're not hearing about plagues and outbreaks of these diseases and these kind of things. And just like later in the semester when we talk about vaccines, you have the idea, this idea that. Sorry, the chat is really good. It's going to take some getting used to. It ruins my train of thought. This idea that our vaccination schedule is the right way to go. Well, it's a right way to go for sure. But the Japanese vaccination schedule looks way different than ours, and you don't see these. Some of their vaccines are delayed 2 full years, and you don't see measles, mumps, rubella running rampantly in Japan. So we can't. It's hubris to think that the American way to do things is always the right way to do things. So, all right. So satisfaction. Those are good things. We'll come back to the antibiotic thing. So, all right. So that's where it starts, right? So where were you even seeded? Where did the microbes come from? I think this week's discussion is from that Rob Knight kind of about this idea So where did where did your antibiotics even come from? So the first major thing is, were you born vaginally or through C-section? Now, I love using science technology to kind of, whether they call it biohacking or some of these compromises. There is a new technique called vaginal seeding. And I will tell you, some people are doing it themselves, like do-it-yourself vaginal seeding, but I don't know if we're there yet. But some researchers at NYU started this idea of vaginal seeding. Baby has to come out via C-section. They swab mom's vagina, basically use a sponge. They incubate the sponge. And then after the baby is born, they seed around its mouth and its fingers with mom's vaginal microbes. So they're basically coating a baby that came out via C-section. So its first exposure to microbes is going to be skin microorganisms instead of vaginal microorganisms. But they're trying to fight that. It's almost like a vaginal probiotic idea, where let's get as many of the vaginal microbes in and on the baby as possible. So that might be a great compromise, this idea of this vaginal seeding technique. So, all right. Yeah, good. Excellent point there, Eva. We're talking about antibiotics. Antibiotic stewardship is great. Infection control committees. One of my ulterior motives in this class is that people will leave this class and someday find themselves in a situation where they are in charge of antibiotic stewardship or these infection control committees where they work, because then they can hopefully have a pretty good grasp of things. I had a student last semester that actually does handle antibiotic stewardship where she works. So that's pretty cool to see. So we'll come back to our indiscriminate use of antibiotics in a little bit. So next then, and again, no condemnation. I completely understand that this can't happen for everybody, but how you're born matters. Then the next big one. So the next big ones are going to be what antibiotics you're exposed to in the hospital. That first trip, your first foray into medicine, and then the idea of breastfeeding. So the two big ones would be, mom could have been given antibiotics during and before delivery because of group B strep. And please, I'm not saying that's not important. The Cochrane collaboration's review on this topic found that if mom is positive for group B strep, administering antibiotics reduces the risk of infections in the baby by 83%. That's awesome, but the story doesn't end there. So I'm hunting down some extra research for you guys. I'll send out the link I was telling you, this whole evidence-based birth website I really like, and they do a whole, oh my God, they do a really good job of looking at this idea of group B strep from every angle, including what did we used to do. Then there used to be options where this ubiquitous administration of antibiotics was one of the different paths you could choose, and then it became, let's do it for everybody. So. And not everyone, but everyone that's group B strep positive. So probably a really good idea, but there are different types of group B infections that babies can get. They can get short-term ones and long-term ones. There are infections that they can get over with pretty easily on their own. There are some they can't, and there are infections that happen right away, and there are delayed infections. So it's a good example of how, even if we never change anything, just looking at it through a new lens and is this the right way to do it makes a lot of sense. So it does work. It does reduce the odds that the baby's going to get this group B strep from mom. But one study here in the United States, and I'll find a link to it and share it with you guys, found that if a baby is given antibiotics or exposed to antibiotics that early in their life, their risk of getting other infections goes up exponentially. So what if we continue the story and we find that the antibiotics for mom, in mom, group B strep, protects the kid from group B strep, but increases the odds that they get other infections in the first month of their life by 100%. Right? I don't know, but these are the kind of tough decisions. So I think that the best thing to do is going to be better diagnostics, putting people in smaller categories, more narrow spectrum antibiotics. Because right now, ampicillin, so in the study that I'm talking about, and I'll link you guys to it, if the baby gets exposed to antibiotics because of group B strep, they are less likely to get group B strep, more likely to get other infections. The other infections they're more likely to get are more likely to be drug resistant. So see, it's never a pretty picture. It's never this clear, concise picture. So I would not... so only for oral antibiotics, the question there? No, the group B, this would be the intravenous antibiotics here too. So that's just that. I don't know how. I'll let the article or the website I will link to and send you guys kind of help understand the group B strep thing a little bit better, because it's a huge topic. But I think it's probably the one where it should be one of the last ones that we target, because it does seem to be pretty effective. But just understanding that if you have, as a mom, have group B strep, baby gets antibiotics, they are more likely to get sick from other infections. So, but this whole idea of the eyes, let's kind of focus on that one more. The eye. So the reason that kids are given antibiotics in their eyes is if mom has gonorrhea and the baby gets exposed to gonorrhea during the birth process, and the gonorrheal infection gets into their eyes, it can cause blindness. So the best data I can find right now is that if we quit doing that, if we quit using those 4 million doses of antibiotics a year, there would be 200 kids that would go blind. Unacceptable, but it's also unacceptable to treat a kid with antibiotics, in my opinion, that just came out of a mom that doesn't have gonorrhea, right? There's a very specific reason to do that. So when we decided to do it to every baby, did we see any consequences? Did we see any downside to using antibiotics? We clearly must not have. It is not difficult to find out if mom has gonorrhea or not. And if every woman that has gonorrhea, if their kids get antibiotics in their eyes, I don't know the number of people that have gonorrhea, but let's say that, I don't even know. Let's say it's even 500,000. I mean, that'd be a massive number. We're still looking at 3.5 million births where that baby doesn't need antibiotics. That's 3.5 million less doses of antibiotics. It slows that counter down to where we reach the point where that antibiotic's worthless. So those are some examples. And I'll come back to what Ava said there about when antibiotics. How dangerous are things going to be if and when we reach a time when there aren't antibiotics. So, which brings us to a pretty big point. So, antibiotic exposure right after a child is born. Those are the two key ways. Can anybody think of any other ways that kids would be exposed to? I mean, there's so many things we talk about here. I want to see what you guys want to talk about. But I think that, as natural of a birth process as possible, makes the most sense to me. The more we learn about how important the microbiome is, the less likely we are to use them indiscriminately. So there's just a couple things we can do differently. What if? Because we'll talk about antibacterial soap, right? Well, what's one of the first things that happens when a baby is born? Their protective coating is washed away. So I know the baby doesn't look as cute in pictures if you do that, but what if we study that and we find out that this protective layer that they're born with will improve the microbiome? Because it's not supernatural to get rid of that immediately. So I don't know. Any thought? Let me check the so. So cryptosporidiosis, there's a question there about a different type of infection. It is just specifically if mom has the group B strep that they need the intravenous antibiotics. So, all right. So these are just huge examples of things we have to look at. So which way baby came out? Were they exposed to antibiotics on the way out because of group B strep? Did they get antibiotics in their eyes? What would this natural protective coating do if we left it on there for a while? These are just a few examples. Then we have, nice. I see here, so somebody was just saying, last baby didn't wash off for 2 hours, promoted skin-to-skin contact. That's exactly what I think it should be, so that's awesome. So we're waking up to this stuff, that the first few moments of a baby's life are so super important. So next is breastfeeding. So I get it. It was a lot easier to breastfeed when breastfeeding could basically be somebody's full-time job. We live in a time now where it's hard for two incomes to work. To make things work. So I think the numbers, percent of kids that are breastfed in the U.S. for any extended period of time is pretty small. So I'm not. I wanted my wife to breastfeed. The World Health Organization actually says 27 months. I would have been fine with that. I'm a pretty big fan of breast milk, but when my wife went back to work, which she had to, she makes more money than me. If one of us got to stay home, it wasn't going to be her. When she went back to work, she was drinking and eating everything she could. She couldn't produce enough breast milk. So my son was breastfed for 8-9 weeks, maybe. So that's better. So to me, it's better than zero. If you can breastfeed for 2 weeks, that's better than none, and 4 weeks is better than 2, and this kind of thing. But so I totally understand why people choose not to breastfeed. And I also understand that people that want to breastfeed don't always get to. So my sister-in-law, within 7 days, she's done no milk, no more milk. Her sister has donated, I think, 50 gallons of breast milk to the hospital, right? I mean, it's crazy how different it can be. So, but it is not, breastfeeding is unnatural. So I'm not saying that as a negative term. I'm not, again, no condemnation. I shared my story, because my wife and I, we wanted to breastfeed Oliver as long as possible, but it's not always possible. So it's pretty rare, though, in human history. For as long as there have been humans, the idea of children not getting breast milk is very, very new. If when we were hunter-gatherers and we lived in small tribal communities and this kind of thing, if you couldn't breastfeed, somebody would. That's what wet nurses were. So the unbelievable majority of humans have been breastfed for most of their young lives. So what does breastfeeding have to do with you? Because you may have heard of breastfeeding and maybe how it impacts IQ, or breastfeeding having certain fats, or you may have heard that breastfeeding is not a good idea. When I was a kid, that was the belief. There was for about a decade, basically doctors were telling their patients that formula is better than breast milk. And today, in some, from a nutritional standpoint, if mom's really nutritionally depleted, that could possibly be true. If mom's got a ton of toxins in her body that are being passed through the breast milk, you could make those kind of arguments. But the reason, breast milk is important from a completely different standpoint than from a purely nutritional one. Two big things about breast milk is it's the only body fluid. I always do that. I don't mean to. The only body fluid that has all classes of antibodies in it. So mom is literally loaning her immune system to her child. But we've adapted to that. We've co-evolved in this situation. So baby doesn't have a complete immune system the first 6 months of their life, because they're supposed to be able to rely on the fact that while their immune system is maturing and they're being exposed to the world, they're supposed to rely on the fact that mom is loaning their immune system to them. So from an immunity standpoint, if you're, there's sadly way too many kids die. I research this quite a bit. I give talks every year for this Iowa Food Prize about malnutrition and water problems and stuff. If every woman was able to breastfeed, we're talking about millions of children whose lives would be saved. So in the developing world where these infections still run rampant. So your child in the U.S. is probably not going to be exposed to many life-threatening pathogens when they're young, but they might be. So that's part of it. But what we're talking about today is the growth of microbes, how we play a role in cultivating the garden that is us. So breast milk has probiotics in it. So probiotics are going to be living organisms that confer health benefits. So mom is directly seeding the baby's gut with probiotic organisms every time she breastfeeds, which is why when my wife could no longer breastfeed, we actually started adding probiotics. And we switched. We can talk about this too, because we also switched after a while. I'll tell you the story. Hard decisions have to be made, and I can tell you a story about how we ended up going all the way to raw dairy with my son, and the concerns I have with that later today. But so probiotic organisms and prebiotics. So have you heard that word prebiotic? Prebiotics are what feed the good bacteria. So we're always talking probiotics because there's money in that. Probiotic pills and probiotic foods, and nothing wrong with any of that. There's nothing wrong with the probiotic nature of breast milk, of course, especially that early on. The first 3 years of your life, your microbiome is really being seeded, so adding probiotics is a really good idea. But prebiotics are more important. When you compare the two, if you want to improve somebody's health, now thankfully we live in a world where you can do both, but if you want to improve someone's health from a microbiome standpoint, prebiotics, which is feed the good bacteria you already have, has been shown to have more impact than probiotics. Probiotic pills, they are effective. I think 10 years from now we'll look back and laugh at how ineffective they are compared to where we're going to end up. Comparing to things like oral fecal microbiome transplants and stuff like that, right? But they're better than nothing. Some studies show they do decrease the risk of diarrheal diseases, and they can actually decrease the risk of some potentially fatal bowel diseases when you're young. So I'm not saying there's no value, but prebiotics are better. That's, to me, the coolest thing about breast milk is the idea of these HMOs. So the human milk oligosaccharides. There are 200 different ones. Humans have more different oligosaccharides. oligosaccharides are like medium-sized carbs. They're what give beans their magical fruit power because oligosaccharides are fermented. So they're fermented. So that means when you breastfeed your child, you're giving them 200 different fiber sources that are designed to help cultivate and grow the right microbes inside in and on them. So if you want to look at, so about 10% of the calories that go into making breast milk are not to feed your baby. They're to feed their microbiome. When I look from an evolutionary standpoint at how important our microbiome is, that's one of the first things I point to. Nature doesn't like species that waste energy, and wasting 10% of the energy that goes into making breast milk to feed these microbes wouldn't make any sense unless it was valuable, unless it was worth it. There are people that think that this is where our massive brain comes from. The fact that our microbiome is being, this massive number of HMOs, human milk oligosaccharides, is feeding this microbiome in a way that increases this is not the theory, but it is one of them, increases what are called sialic acid levels. And sialic acid is a compound that appears to help aid with brain growth. So now I think that there are important theories that I do believe that there is a connection between our gut and our massive brain. So the biggest one is called the expensive tissue hypothesis, which says that by cooking our food and by having a microbiome that aids in the digestion and absorption of nutrients, we could devote less energy to our gut than most other species. Like a gorilla has to eat 15 hours a day to extract nutrition from the food they eat. We were eating very nutrient-dense foods, cooking it, and extracting nutrients in that way. Our microbiome helped us extract nutrients in other ways. And the fact that we could get more nutrition from every bite of food freed up a lot of energy that went into our brain development. So I think there's definitely a connection there. But whether you breastfeed or not is I don't want to go too far into that, but it has a massive impact. So if you're born via C-section, but before emergency C-section, you were already exposed to the antibiotics for Group B strep. So you're born via C-section, exposed to antibiotics while you're still in your mother, and then they put antibiotics in your eyes, and then you're not breastfed. That is a totally different microbiome than born vaginally, no antibiotic exposure, and you're breastfed. So there's no condemnation there. I'm just saying it's not. It's a completely unnatural microbiome that would have developed out of that. So any thoughts specifically about that? And then I'll see what's in the chat here, and then we'll move on. Anybody hear anything? So now we're leaving the hospital, and we'll see what goes on there. So. All right, so vaccines, delaying vaccines, and breastfeeding, and these kind of things. That's something we'll talk about that in chapter 18. The idea that I like to use personal stories just because to show you the kind of the thought process that goes through making these kind of decisions. That's what I want you to leave with today: is that tough decisions are going to be made. Our food's going to be more expensive. Our kids are going to die. We're going to have to get better diagnostic tests or kids are going to die. Because the end is always kids dying because our antibiotics are going to run out. So if we're not smarter about it. And of course, hopefully new generations of antibiotics show up. We don't have to worry about this. So show of hands, who that I can see anyways. Who was born at 1994 or later? Right? Lots of you. So your entire lives, there's never been a new class of antibiotic. We've made some antibiotics better. And we have new variations on old antibiotics, like vancomycin doesn't look like it did in 1994. But there hasn't been a new class of antibiotics in your entire lifetime. Every time a new antibiotic shows up, it's a variation on an old theme that microbes have seen before. So the new antibiotics that have come out, they're not going to work as long as they used to. And for every time an antibiotic gets put on the market, 2 are being taken off the market because they no longer work. So it's a scary scenario that we're in. So we have to make smart, tough decisions about all these things. So the idea of delaying vaccines, let's say that's a big discussion, but let's save that for because we've delayed some of our vaccines. We don't use the vaccination schedule. I am absolutely pro-vaccine for the huge majority of vaccines, but we'll talk about the vaccine schedule is a whole different thing. So let's save that for chapter 18, though. That's a big topic. So let's see. Kelsey brings up a good point here. With the fecal transplants, did you look for a donor within the environment of the recipient because of their similar exposures? Wouldn't it be similar with breast milk? How could a neighbor? So this is good. So yeah. So That's a neat discussion to have just on its own. So, because I don't know if I agree with that. I mean, you're right. This is what they do, but I don't think that's a good idea. So, if someone needs a fecal transplant, especially a few years ago, now you're seeing a lot of the fecal transplants are actually getting their donors. They're getting the fecal material from that company in Massachusetts that. I think it's actually a lot of like MIT students and Harvard students are getting paid $12,000 or $13,000 a year to donate stool. They get shipped around the country and the world for fecal transplants, which I think is good. These are highly vetted. They actually say it's harder to get into MIT or harder to get into this company that sources fecal microbiota transplant material than it is for MIT. So much so that they have, because people are doing, you can Google it, I'm not going to teach you how to do it because I don't think you should, but there are do-it-yourself fecal transplants. There are people that are doing this on their own. Because right now, let's say you have inflammatory bowel disease or some serious autoimmune disease and you want to try a fecal transplant. Too bad. The FDA only approves it for the C. diff infections in the United States. So either you leave the country and you spend $20,000 staying in England where they give you a series of fecal transplants or something like that, or you do it yourself. So I'm not faulting people for trying things when you've exhausted other options. But so much so that this company, this Open Biome company, they have security because there are people in the parking lots trying to negotiate with people to buy their poop so they can try fecal transplants. So I think you're seeing less and less of that, but that's absolutely how it's been. For fecal transplants, they usually take someone you live with, someone that has a similar past to you. And I understand that to some extent because it's less of a shock to your system. And I believe that I think that made perfect sense for years. But then I was probably one of my drives. I kind of had this moment where I thought, well, that doesn't make any sense, right? Because you're sick because your microbiome sucks. If I need a fecal transplant, don't give me one from someone that lives in the same environment because that clearly isn't working out so hot. So I think the idea would be you want a wildly different, what we would call maybe a wildly better fecal microbiome when you're done. So that now, which is why these companies they actually quarantine the samples for months while they run all manner of tests on these people because I might be perfectly healthy and not have any diseases from my fecal microbiome. I could give it to you, and because we have different immune systems and different exposures and experiences, you could die from some infection that's there. So I'm really glad that they vet these people, they quarantine these stool samples, they run tons of testing on them to make sure they're good. But yeah, I would say if I needed a fecal transplant, I would want a wildly different one than my wife's, because we're exposed to the same dogs, same kids, same everything else. I would want a different one personally. So, but that is true. That's how they've done it. So the question was kind of like with breast milk. Yeah. So if you're getting breast milk from a donor, I mean, I've seen where you can buy it on eBay, and I know hospitals have it and stuff. And now, a few things there. They do pasteurize breast milk when it comes from someone else, and what does that damage in the breast milk? That's this kind of discussion for another day. But yeah, the idea you would want if let's say let's go back to medieval times or something, and you were a wet nurse and you were nursing someone else's children. You would hope that the woman that's nursing breastfeeding your child would have had very similar exposures to you or to what the baby's going to be exposed to. So yeah, I think if you were to get just a scenario here, if you were to get breast milk shipped in from a completely different part of the world, where the mom producing that breast milk had fought off malaria and tapeworms and all manner of that stuff, but hadn't seen what you were exposed to here, it probably wouldn't be as protective. Because you want the breast milk to be protecting the baby from what they're actually being exposed to. That's why look at what happened when the Spanish conquistadors came here. Depending on who you ask, 80, 90, 95% of the people that lived wherever they went dropped dead. Now, we could have a complete discussion about that, maybe we will. This idea that, of course, the people were malnourished, they were enslaved, there were lots of factors that went into that, but the reality is, people have been living here in the New World for as long as they've been here, fighting infections, and the ones that were alive were the winners, but the infections that came here were different. So people were dying from, measles and diseases that maybe that we already hear, but the versions they were getting exposed to were different. So, think about that. 200, and I really like. It's sad, but I love the history of how microbiology has affected us as humans. And a big part of it is the way the world looks. If you're interested in that at all, let me know. I can tell you about a few books, but there's one really good book called Guns, Germs, and Steel by Jared Diamond's the guy's name. And they did a 3-part series that used to be on Netflix. I can't find it there anymore, but it was called that, Guns, Germs, and Steel. If you ever find it, just watch the germs one, because guns and steel matter too, but not in this context. So 200 Spanish conquistadors come to the United States with microbes that they were immune to, but were tougher than anything the people in the New World had seen. So you have these guys running around with silly metal hats on, and everyone around them is dropping dead. So the people that were still alive thought they were gods or something, right? So 200 people conquered, initially the New World with the help of these microbes. So the bioregion matters a ton. That's why if you ever watched the show, it's on Animal Planet. What the world? With the all-out parasites and stuff, people. It's like 6 or 7 seasons. I didn't sleep well last night. I hate when things are on the tip of my tongue. Monsters Inside Me. Thank you. Yeah, I own like 4 seasons of it. If you ever watched that show, it's like I left my bioregion and came back and almost died. Right? That's how it is almost all the time. There's one episode called Homegrown Killers that talks about things that people are going to be exposed to here in the U.S. But it's almost always went on vacation, went on a honeymoon. Either I went somewhere and came back and almost died, or the food I ate was from somewhere else and I almost died. And you're immune, even in the U.S. though. If you go to the southern United States, tuberculosis is a bigger problem. You go to northern United States, histoplasmosis is a bigger problem. So even in the U.S., there are different bioregions. But if you were going to be using someone else's breast milk, it would make sense that you're from that bioregion. Now you could make that argument maybe with the stool too, that at least you be from the same bioregion. But I just think, especially with the limited research about fecal transplants and how they can affect your weight, like I definitely would take. If I was going to take a relative's microbiome, I would take the skinniest one I could find, just in the hope that would help. So what were you going to say?
Maybe I'm off base, but isn't it alarming? People get breast milk from whoever, and isn't that a big way for babies to get HIV?
Well, again, this stuff should be tested and pasteurized. But if you're getting it, you need to trust the donor, which is why no one would advocate that you don't go through a hospital. But I know you can. I mean, I don't know if it's on there anymore, but I have gone on eBay and saw where you could get it, and things like that. So.
I know a girl that is getting breast milk from another person that's like hepatitis, whatever it was.
Yeah, you're right. You should have them do some testing. You should definitely know. I mean, that's the way I think about it. Same thing with vaccines. When we have the discussion later, you should know as much as you can about anything that goes inside your babies. Like that's just the way I see it. So, which I'll tell you about our experience with raw dairy too, because the CDC would say you're insane to do that and these kind of things. But you should know the idea. I mean, so this whole pro-vax, anti-vax movement. We'll have a whole 2-hour discussion about that. I don't want to do it too much here today, but. If you blindly don't believe in antibiotics, I think you're wrong. But if you blindly trust in them, you're wrong too. Like you're literally letting people dump chemicals into your kid, and you've never been informed. You've never looked into it. Like that's all I want to see is find as much information as you can and make an informed decision. So in the end, that's where I hope we all will agree, no matter what your stance is. I hope it's not blind faith on either end. So, I think whether it's somebody else's breast milk or, I'll tell you about why we use raw dairy and what I did before we made the decision. You should absolutely have these things tested. So, that's an excellent thought. So bioregions matter. There's a question here. So, recommend prebiotics over probiotics. If you had to choose one, I would, actually. So, the studies have shown, because, most probiotics, you go to Walgreens and buy a probiotic, most of those organs are going to die. They're not going to survive the trip through the gut, the stomach acid. And those that live usually have a transient effect. And I'm not saying that's a bad thing, but if you're trying to get the health benefits of probiotics, whether it's probiotic foods or pills or whatever, you should do it on a continual basis. So my opinion's changed over the years too because of research. I'm not saying every day you got to be on a probiotic. But 10 years ago when I started teaching at this class, I would have said everyone should do a round of probiotics once a year, just kind of top off the tank. And then you should use probiotics for twice as long as you use antibiotics. So if you're taking antibiotics, you should be taking probiotics while you're doing it, and then take it. So if you have a 10-day dose of antibiotics, then 10 more days after that with more probiotics. That's how I used to believe that. Now I think it's on a more regular basis, whether it's probiotic foods, occasionally adding probiotic pills. most of the health benefits of probiotics are transient, which means the microbes that are passing through you will have an impact. They will modulate your immune system. They will affect your health. They, like I know people that take probiotics just because of halitosis. And as long as they stay on a schedule where they take probiotics, maybe 2 pills a week, it's there. It goes away. But when they stop, it comes back. That's what I mean by transient. It's not going to be a permanent impact. And prebiotics won't either. But prebiotics it's basically fiber. You eat a diet higher in soluble fiber, and there might be some gut upset while your body transitions. Like I know when I go in and out of like how many carbs I eat, because I'll go completely ketogenic for a while and I'll add carbs back. Like it causes some issues, right? These transitional periods can be tough. Like if every January 1st you're like, I'm going to eat 3 servings of broccoli every day and 35 grams of fiber. Like there are people that go to the hospital thinking they have an appendicitis or something like that. I mean, I've seen people that I thought were going to die and it ended up being they ate too much fiber. So. If I had to choose one or the other, I think that the prebiotics, feeding the good fermentative bacteria you already have, will have a larger impact. Now, it's been shown in studies as far as your stool volume will increase more, some symptoms will be better. So, yeah, I do think that if you had to choose one or the other, make sure you're getting more soluble fiber in your diet. But thankfully, we can do both. Make sure you're getting more soluble fiber in your diet and eat sauerkraut a couple times a week. And take a bottle of probiotics every 3 or 4 months, whatever. You can do all these things. So, but yeah, if I had to choose one or the other, I would. And the studies would back that up, that prebiotic fiber is more beneficial than taking living organisms. So, especially, like, no offense to yogurt. I love yogurt, Noosa yogurt's so good, like my favorite in the world. But you have to understand that stomach acid is part of your immune system, and it's one of your non-specific defenses, and its job is to kill things that try to come through it. So, what percent of the bacteria in the Noosa yogurt is going to actually make it to my bowel? It's a very small number, very small number. Even probiotic pills, which are going to be very concentrated, and some of them have acid-resistant capsules. Even them, a lot of your brands of probiotics, only 5% of the bacteria are even going to make it to your colon. So feeding the good ones that are already there does seem to have a bigger impact. So that's a good question. Yeah, and again, so seeing there, just talking about the fact that you had a kid via C-section, they do have more of these problems. I can't take any one story and hold it up, but statistically speaking, that is what's going to happen. If a kid is born vaginally, they're less likely to have these problems. So this is good. So drinking probiotics. So as far as where we get probiotics, let's see, breast milk. Yeah, tested at the hospital, and that's pretty smart. So exposure to antibiotics and probiotics. We'll just this is good. Your good line of question here. So what do? We go all the way back. So C-section versus vaginal birth has an impact. Antibiotics have an impact. The average person in here was exposed to antibiotics 17 times in the first 20 years of their life. That's what the most recent research I can find, shows that you were given antibiotics 17 times in the first 20 years of your life. So, now I'm not saying you shouldn't have been given antibiotics, but this is where the whole idea of antibiotic stewardship comes into play. We want to use antibiotics. What we don't want to do is abuse them, misuse them, or overuse them. And then where we draw that line is going to depend. I think in the year 2000 or 1990, when a doctor was giving you amoxicillin because you had a cold, they didn't think they were abusing antibiotics. They were trying to make their patient happy, and they this whole idea they would. That's why I don't like the term secondary infection. It's like this term that was used to justify this waste of antibiotics. Because do secondary infections exist? Absolutely. I mean, C. diff is a secondary infection if you ask me. Or candida infections and these kind of things. Secondary infections exist. People that get the flu are more likely to get bacterial pneumonia. So I'm not saying secondary infections don't exist, but I'm saying treating everyone that came to you with the cold and the flu with antibiotics under the guise of secondary infections was a mistake. So hopefully the line is moved. We're not where I want to see us. But again, I don't practice medicine with a lawyer looking over my shoulder. So I get why the line isn't moving as fast as I want to see it move, but I want to see the line move. So, whether you're breastfed or not is going to have an impact. All these things have an appreciable impact on your microbiome, the bacteria living in and on you. So let's just continue that discussion then. So exposure to antibiotics. The later the better. The first time so not even counting the antibiotics you were exposed to in the hospital. The later your first course of antibiotics in life, the better. If it happens, if you have to get antibiotics at 1 month old, that's worse than 3 months, which is worse than 6 months, which is worse than a year. So, if a kid can make it 3 years and never have been exposed to antibiotics, that'd be awesome. But just globally speaking, exposure to antibiotics has a relatively short-term impact. Now, here's what I would say, and I think Rob Knight's TED Talk that you guys are watching will show the same thing. You're 1 year old, you get antibiotics. It might take 2 or 3 months to get your microbiome back, 8 weeks, 14 weeks, 16 weeks, depending on which study you look at. It'll almost come back though completely, and you'll see that with his talk. But it never comes back exactly the same way it was. So I think that over the long term, an exposure to antibiotics, especially after the age of 3, isn't a huge deal. But your microbiome will never be the same. So I want to look at antibiotics the same way as I look at everything through a risk-reward standpoint. I like to practice what's called the precautionary principle. It's a very European way to live, right? So I'll just give you an example. It has nothing to do with microbes. So like phthalates. Phthalates are these chemicals. You can buy phthalate-free toys. Phthalates are what make plastics flexible. So the new car smell would be phthalates being off-gassed from your car, the soft dashboard of your car, this kind of thing. So phthalates are testosterone disruptors. And we don't know how bad they are, but the assumption is that they do come with some risk. I mean, you have a developing boy or girl at home. Testosterone matters for everybody. But you have a developing boy at home. I would just argue that the less testosterone-disrupting chemicals are around, the better. So the precautionary principle says, like in the United States, it's legal to have things with phthalates in them because they haven't been absolutely proven to cause problems. Now, it takes decades for that to happen, though. Like the triclosan is being removed from antibacterial soap right now. We'll talk about that in Chapter 20. Triclosan is being removed from antibacterial soap, but it was first brought to the attention of the government that triclosan is a hormone disruptor in the 1970s. So the precautionary principle says, I don't use chemicals. I avoid the ones I can until they're proven safe. The U.S. model is more we're exposed to whatever, and then when we find out something's bad, we get rid of it. So I just kind of generally have this thought process where I look at things through a risk-reward standpoint. So the risk of trying to avoid phthalates, probably spend a little more money on toys, a little more time researching, like what plastic bottles I want to use, right, this kind of stuff. A little bit of time, a little bit of money. Best case scenario, 20 years from now, we find out phthalates were really bad. And I can say, you know what? I helped my son avoid them as often as I could. Worst case scenario, you do nothing. And yet there's phthalates in their chew toys. And we find out phthalates are bad. We can't unwind that clock. So I just generally, I like to look at things, I try not to be, it's not pessimistic, it's just kind of, I like to look at things through like a kind of a cost-benefit analysis, risk-reward situation. And then if the reward's not big enough, then the risk is too big, in my opinion. So phthalates is a kind of non-microbiological example. But if we're looking at antibiotics, so right now, if I was your doctor and you were sick and I had to decide, should I give this person antibiotics? And it may have a negative impact on their health 20 years from now. It may increase the risk that they get allergies. But no one can pin that on me. Like one of the posts was about when are doctors going to be held accountable. No one can pin that on me. So if there's any risk to giving this person antibiotics, it's in the future and it can't be pinned on me. Well, what's the risk of not giving them antibiotics? They die or get sicker for an infectious disease. They sue me for malpractice, and then they bring in a coworker that says that I didn't practice standard of care, and I lose. I lose my license. I lose a ton of money. I lose my reputation, right? So that's where we are right now. So when doctors are deciding whether or not to give you antibiotics, let's use that strep infection. That's a really good example. I'm going to take a drink here. All right, I'm getting a message here that it's too loud in Denison, so But try to pay attention. That's the beauty of Zoom. If you don't want to be here, you don't have to be here. But so strep infections. 95% of people that have strep throat, positive strep test, positive culture, will not need treated. See, we know that if you don't treat strep throat, and 10 days later someone still has a strep infection that hasn't run its course and your immune system hasn't beat it, there's like a 1 in 5 chance that they'll actually develop heart muscle damage. So the reason for that is it's a concept called molecular mimicry, whereas your immune system, so that 10-day mark is when your immune system finally ramps up. It takes 10 to 14 days for the primary immune response to kick in. Now these IgG antibodies are out there kicking butt and taking names. But the problem is the strep organism, at least part of it, looks like heart muscle tissue. So as those antibodies are out mopping up strep, they're also attacking your heart. It's just that collateral damage. It's a innocent bystander that looks too much like the strep organism. So we do know that if no one gets all right. So we know that some people need antibiotics, but we're at a point now where we can't. We don't know who. And it's not even severity. The 5% of people that need treated for strep infections, we don't actually know who they are. We can't even say if you have really bad strep, you're one of them. If you have really mild strep, you're not. So what do we need to do here? At this point, I completely understand why doctors would give antibiotics to everyone with a positive strep test, or if they have a negative quick strep test, everyone that has a positive culture then a day or two later. Because we kind of have to. So the solution here, how do we save the 95% of antibiotics that are being quote unquote pseudo overused? Better diagnostics. How do we figure out which strep organisms are the ones who have to be most concerned about? Like which subspecies? We're all humans. Which of us are carrying knives, right? Something like that. So we need better diagnostics as far as the organism goes, but then also the people. So in the future, we might actually find out that there's a certain genetic profile that makes you more susceptible to that long-term damage from strep. So in the future, let's hope 2 things happen. Only 5% of people that have strep throat are given antibiotics. And the other thing we have to do is get better about the spectrum of antibiotics we use. So we might be talking 50 years from now, but only 5% of people with strep infections are given antibiotics. And number 2, they're given a narrow spectrum antibiotic. Right now, narrow spectrum literally just means, do you kill all gram-positives or all gram-negatives? The hope is in the future that we'll truly have narrow-spectrum antibiotics. Here's the drug you use to kill strep, right? Let's hope that that's what we see. So we're going to be using smarter antibiotics and using them more judiciously. So that's just one example of what decisions do we make when it comes to antibiotics. So let me see here. So, all right. So you're talking about, what's the patient's, and that's a good point. So the question here about, should we really be blaming doctors and what should patients know? Well, I think, especially we live in a time where there's a lot of information out there. You can be a more informed consumer now than ever. But there are some areas where it's difficult to be informed. Like with the vaccine debate, almost all information comes from one of 2 very extreme camps, which means you have a hard time knowing what's true and what's not. Have you guys watched the news recently? The reality is that just because we're exposed to information doesn't mean we can actually figure out the truth. I do agree that like I said about vaccines, you need to do everything in your power to be as informed a consumer as possible. But the system is what I really think needs to be changed. But you're right. If you're, and I'm glad every time I go to the doctor's office now and I see signs up that are basically educating people about this is a viral infection, antibiotics don't make any sense. And then I've even seen, I saw one doctor's office, there was a note that said, basically kinder words than this, don't even bother trying to ask for antibiotics if it's clear you have a viral infection, because we're not going to do it, kind of thing. So I'm hoping a generation from now everyone gets that, but the medical doctor is 10 years behind the scientific literature. Imagine where the general public is. So it's going to take time, and that's why I don't want to blame anyone. We all need to become more informed, and because the doctor might prescribe antibiotics because they have a poor understanding. They might prescribe antibiotics because of their concerns about legal issues and stuff, or they might prescribe them because the patients are demanding them. And in the end, I would hope that every doctor would stand up for what's right, but you can see why. I mean, my wife used to work at the community health center in Sioux Falls, and there are doctors that the games people would play to try to get opiates and these kind of things, and just unbelievable. The things that would happen there. There were doctors that were way more likely to prescribe them because they were just tired of the fight. So the reality is doctors are humans. Just scientists and doctors, they're not objective robots. That'd be awesome if they were, but they're not. And you can look at that too, like at hospitals. That's why I like this whole idea of antibiotic stewardship programs and these infection control programs. They're starting to keep this kind of data. You can go to Johns Hopkins University, and you could look at now you can't, but they keep this. Every medical doctor, they keep stats on what % of their patients get antibiotics and what % of their patients get this and that. And when you look at this, so you can go to a hospital like that, and you can find that Dr. A prescribes 4 times more antibiotics than Dr. B. So we have to find out why. Now, could it just be random, dumb luck? That's why you got to be really careful with small sample sizes. But could it just be that they had more bacterial infections come through their door? Maybe. But chances are, if that's a trend, that needs to be addressed. Now, is it possible Dr. A is not prescribing enough antibiotics? Or maybe, I don't remember which one I said was which. But is it? Or is it more likely Dr. B is still overprescribing antibiotics? These are all things that have to be dealt with, and it's going to take a generation or 2 before I think we all get on the same page. So, question? Oh, I just stretch. All right. So, yeah, so Trisha's talking about refusing antibiotics. I think that if you're an informed consumer, now it's all, and that's when I read that I thought something here too though. It's all well and good until it's your kid, right? We all understand that we should not be abusing and misusing and overusing antibiotics. Then your kid gets sick. You're talking about how you did object to them, and we've done that. We've told doctors, no, we don't even bother writing the prescription. My wife has a knee replacement, so she's supposed to take antibiotics. At the drop of a hat. She's not supposed to go to the dentist without taking antibiotics and all manner of things. Now I looked into again, trying to be an informed consumer, but I don't expect Joe Schmo to be able to know what I know and research what I research. But I did a deep dive, just like I'll tell you about with the raw dairy here in a moment. We found, in Canada, this is not a requirement. Just this whole idea that because it's the way we do it in America, it has to be the right way to do it. There has not been any research that shows that prophylactic antibiotics prior to dental work, teeth cleaning and such, it will decrease infection rates. So that's the decision. I'll take you through the whole process here. So we looked at all the research. We found that in Canada it is not a requirement, and there's not a bunch of one-legged Canadians because they got their teeth cleaned, right? But the surgeon, which we really trust, we trust the surgeon. He's actually a friend. The guy that did the knee surgery, my wife is a friend, and he actually took a video. One of the nurses took his phone and took a video. I don't know, it's probably totally illegal, but took a video not during the first surgery. But she developed this arthrofibrosis condition in her knee where her knee locked up because of a hematoma. And so 3 months later, they had to go back in and basically just rip it apart. So he's like ripping my wife's knee apart while somebody's taking a video because we're friends. But so I'm going to tell you that we made the decision. And I'm not like the king of my castle. You have to understand that I didn't tell my wife, you're not taking amoxicillin before you go to the dentist. But we looked at the data. We made the decision that it didn't seem to make sense. But does my wife take amoxicillin before she goes to the dentist? Yes. And this just kind of shows you how things work. The surgeon had another patient who got an infection after going to the dentist. Did that change the probability that my wife was going to get an infection if she took amoxicillin or not? No. Did it change the data that we found? No. Did it change the Canadian way of doing things? No. But it made it personal. And, right? So now my wife has decided that the risk of taking antibiotics she doesn't need is lower than what may happen if she doesn't. That's what I mean when I say we can all talk about these kind of things, and then it's your kid, and if there's a 1% chance that antibiotics are going to keep your kid alive this week, you don't care so much about allergies, do you? Right? I mean, this is tough. These are tough decisions that have to be made. So, all right. So there. I'll come back to the chat in a bit, but let me tell you my story about kind of the path we chose with the food issue. So my wife could no longer breastfeed, and it was too bad. Like, you have to understand what I expected. I took my wife and the older kids to a petting zoo twice when she was pregnant. Like, I took her out to the farm where we get our eggs. I took her to the farm where we get our milk. Like, or our meat. We didn't get our milk there at the time. Like, I'm all for exposure, and I'm all for diversity of microorganisms, and I'm all for kids playing in the dirt, and I'm all for this and that, right? And the plan was to breastfeed as long as she could, and I was super stoked about that because I'm a firm believer in breast milk. The plan was not to have them be exposed to antibiotics. My goal was to get them to 18 without needing them. This is just the problem. This is how things happen in our head, and then things fall apart because, I don't know. He's probably 7 or 8 weeks old the first time one of his eardrums ruptured. It was right after, so basically, and we don't even know what to blame. My wife, breast milk dries up right when she goes back to work, but he also starts going to daycare at that time. So he goes from breastfed at home to formula daycare. So he's allergic to the formula. Something's going on with the formula. We don't know what yet. But the formula is causing lots of problems. He's just tons of snot and everything. Going to daycare, no longer protected by breast milk, ruptures his eardrum. Needs antibiotics. He's not even 2 months old. I'm like, holy crap. This just isn't the way I envisioned it. Because I know how important the microbiome is. So it hurts me, but I'm not going to say no to antibiotics. He clearly needed them. Ruptured his eardrum. Happens 2 more times. So, over for 7 months straight, he's basically full of snot, ear infections, ruptured eardrum 3 times, and then so much so we took him out of daycare because I'm all for exposure, but exposure to microorganisms and exposure to pathogens or too much exposure for your immune system to handle, those are different things. So I can point to the research that shows that having a kid in daycare has this protective benefit, but it wasn't working, right? It wasn't working for him. So everything comes down to these personal choices that have to be made. So take him out of daycare, gets tubes in his ears, which was amazing for a couple of reasons. The doctor said that what was in there, he said it was like just the thickest, grossest snot, whatever was in there. Like it wasn't coming out. So the tubes were a brilliant idea. He did need antibiotics one more time after that, but then they can use the antibiotics right in the ears, which I like that idea. Let's as local as possible. So tubes in the ears, out of daycare, and then we got off. So then the choice, what do we do with the food? So can't be breastfed. So we tried all these formulas. And we had considered raw dairy. We were looking into it. But there is a risk. I mean, the CDC and FDA would tell you absolutely not to consume raw dairy. There are a handful of infections a year. There's like a 0.0005% risk every time you consume raw dairy that you're going to get infected with something that's in the dairy because it's not pasteurized. But so I did a lot of research. I read a book on the subject. I found a bunch of research from a team at the University of Wisconsin. I was just all over the place on the internet. You find out when you're on the internet too. Again, there's lots of zealots on every side. It's really hard to get to the truth. But so I'm worried about this. I'm intrigued by raw dairy because it's probiotic. It's got millions of organisms in it. It's a probiotic food source. Most humans that consume dairy, and you could even make the argument should we consume dairy or not. That's a separate topic. But most humans that have consumed dairy would have been raw dairy coming out of a cow, right? So I saw it as a good source of protein, good source of fat, probiotic food. Downside, there's a risk of Campylobacter infections, E. coli, and these kind of things. So, but then when you do the research, it's just I'll just walk through the whole thing. Like if we're concerned, so the CDC, FDA would both say absolutely not to raw dairy because there are concerns. But if you're from a per capita, only about 7% of Americans consume raw dairy, so we can't look at absolute numbers. But per capita, per 100,000 people, whatever you want to look at, if you're afraid of raw dairy, and I'm going to step back a little bit. Why I researched it so much? Oliver wasn't even born. I wasn't even married when I started researching raw dairy, just superficially. And that was because I fought 2 years in a row here in Iowa for legislation that would have made it legal to buy raw dairy from a farmer. No one was ever trying to get in the grocery store where you could accidentally buy raw dairy and you weren't an informed consumer. But right now in Iowa, not in South Dakota or Nebraska, but in Iowa, it's against the law to buy milk from out of a cow. Right? I just find that crazy. So the libertarian in me was fighting for raw dairy. I don't drink milk, I don't like milk, and it's just phlegmy. I like yogurt, I love cheese, but I don't drink milk. So I fought for raw dairy before it was ever a personal thing to me, just because I thought it was crazy that you can go to the store, you can buy Hawkeye vodka, you can buy cigarettes, but you can't go to a farm and buy milk if you want it. And you still can't. We lost both times. So that's kind of how raw dairy I put on my radar. So then we're looking at it thinking, should this be something we do for our son? And I looked at all the data. I went to the farm. See, again, I tried to be as informed consumer as possible. Went to the farm, saw their microbiological testing. They do 4 times more testing than the government requires at this farm. It's a Mennonite farmer. I really like them. Never once even a positive sample. I saw 5 years of microbiological data. So if you ask me, and this is why I also don't make decisions for other people, if you ask me, should I vaccinate my kids? Should I get my latent TB treated? Should I consume raw dairy? I'm not going to tell you. I'm not going to tell you what to do, because I could be wrong. I could tell you raw dairy is the greatest thing ever, and the first time your kid has a glass of that milk, they get an E. coli infection from it. So I don't make those decisions for other people. So, but if you ask me, should you use raw dairy? I would say, well, let me see the data. Let me see what that dairy has. So 5 years worth of microbiological data. 4 times more testing than required. So I felt good I felt as good about raw dairy as I could, looking at this microbiological data. So I saw the cows; they were living in clean, healthy environments, and everything else. So, all right. So so I see this, and we still haven't made the decision. Haven't pulled the trigger. I saw lots of pros, but there was cons. But I was getting at, when I was looking at all this data about foodborne illness and the concerns with raw dairy, like if somebody tells me, because I actually met a farmer that says I'm crazy for giving my kid raw dairy, and my response to him was, if you're concerned about foodborne illness, then do you actually, pasteurized dairy causes more infections, because usually contamination after the pasteurization process. So pasteurized dairy is more likely to cause a foodborne illness, but that's nowhere near, like, do you ever eat deli meat? Do you ever eat pizza? Like, these things are off the charts. You are so much more likely to get foodborne illness from pizza or deli meat than you are any kind of dairy. Or, so again, just kind of this whole thing, we have to just weigh and balance all these things. But in the end, I still wasn't ready to pull the trigger. With a decision that actually made us go down that path, and we're super happy we did. He's almost 4. We still give him 2 glasses of it a day. I'm a big fan of it. Again, I'm not going to proselytize you guys about it, but I'm happy with what we did. But I don't even know how much credit to give to raw dairy, because we took him out of daycare and got rid of he has lactose intolerance. And you might be thinking, well, how does dairy help that? Well, raw dairy has the enzyme lactase in it. When you pasteurize it, it destroys the enzyme. So he can have cheese and yogurt, because the fermentation process gets rid of lactose. He can't have regular milk, but he can have this raw dairy. So we're looking at that, but here's where the decision actually. Here's why we made the decision. The special formula the doctor prescribed that we got, I'm looking into it, and the first ingredient is corn syrup. And I'm looking at these ingredients, and like 4 of the first 6 or 7 ingredients were either industrial nut and seed oils or carbohydrates, sugar. So there was dextrose, corn syrup. Trying to be an informed consumer, I called the 800 number on the container and said, you're telling me that this special formula for kids with health problems, the first ingredient is corn syrup? And their answer was, it's not that corn syrup. So what do you think they meant by that? What they were saying is it's not high fructose corn syrup. High fructose corn syrup is 55% fructose, 45% glucose. Corn syrup is more like 50-50. So it's barely any different. It just doesn't call that. So they were basically just trying to say, oh, don't worry about it. It's not high fructose corn syrup. But high fructose corn syrup is barely high fructose corn syrup, right? So I talked to the doctor about it too. The doctor thinks we're crazy. He's totally been cool with it, but and he knows Oliver's like super duper healthy and everything. But he thought we were crazy at first. And I said the same thing. I said, so what I told them when I called them and when I talked to the pediatrician, I said, you're afraid that my son's going to be exposed to a pathogen in this milk, which I get. But you're not afraid of building a brain out of corn syrup. Like, honestly, that's like a huge deal to me. I don't, that's what it came down to. There's risk reward, 0.0005% risk every time he drinks a glass of milk that he get exposed to a pathogen. Building a brain out of corn syrup. That is honestly the final decision that I had to make. And I don't pick fights on the internet or anything like that. But this has always been a topic that's really stuck to me as far as it was after Sandy Hook. That's probably been 10 years now already. I remember doing this post, and I don't pick fights. I don't get political on the internet. I just put pictures of my kid on Facebook, and that's about it. But I share my Grow Gray Matter site. I share like motivational quotes and stuff. But I don't pick fights on the internet. I've been in 2 in my life, and one was about somebody was on the internet saying that they don't use antibiotics in the food supply, and I'm like, you are ridiculous. But we can talk about that at the end of the day. But I put this idea, everything going on. We all look at culture today, and everyone wants to talk about millennials and this and that. We've got school shootings, and there's not a neurodegenerative disorder that's not on the rise. There's not a health problem that's not on the rise, right? We got all these health problems, but we got the behavioral. So more kids have attention deficit disorder, more kids have anxiety, more kids have depression. And I am not trying to say that all of it is nutritional. I think the microbiome has a big impact. I think the society we live in, there's a million factors. So I am not saying that whoever went into Sandy Hook Elementary, it was because their brain was made of corn syrup. But I think that all these things that we're exposed to in this modern world have changed us. So to think that we want when somebody does something terrible like that, we don't think that they're being rational, right? We think there's something wrong with them. We talk about mental health stuff, and that's we should. But why would we expect? So the argument I made all these many years ago is, why would we expect a brain made out of Twinkies to be as a functional? Like, why? So that's where you can think I'm crazy, and that's totally fine. But that is what the decision came down to: is the short-term concerns of exposure to pathogens in the food supply, or the long-term concerns of building a brain out of junk food. That's honestly how we got to our decision. So I'm just I've told you a couple of stories from our last few years with Oliver, just to show you that you need to be an informed consumer. Tough decisions do have to be made, because they're either being made now or they're being made for us in the future. So let's go back to what somebody said earlier, the idea of what a world without antibiotics would look like, right? So if we keep doing things the way we're doing things, and we run out of antibiotics, what's that world going to look like? Well, I already showed you that kind of introductory video. But so if someone says to you, well, I think we shouldn't change how we look at group B strep, or I don't think we should change what we do with these kids' eyes, or I don't think we should change how we decide to give a 1-month-old antibiotics and when it's necessary and when it's not, or I don't think we should change how we treat strep throat. And their answer is usually because, in the short term, doesn't it make more sense to treat everyone with strep throat to keep some people from getting heart damage? It does. And just keep that counter in the back of your head, though, and realize that when that counter reaches 0 and that antibiotic's worthless, protecting people that didn't need protecting versus not having antibiotics. And I hope we never reach this point because we develop new antibiotics or we start using phage therapies and nothing. But when we reach a time where we literally don't have antibiotics and having a C, so right now we're trying to say, should we have a C-section for convenience, right? That's what we're saying. But what if the antibiotics we have to use because of a C-section done for convenience makes it so someday, 118 years from now, somebody has to have a C-section without antibiotics, right? So these are all things I want swimming in your head. I want you looking at, when you look at yourself, I want you looking at yourself as an ecosystem. When the choices you make, it's like we got this, some sort of oatmeal up here. So the nutritional choices you make and how that impacts your human cells, but also how it impacts your microbial cells. These are all things we should be looking at. So let me look around here. So. Yeah. I'm not blaming the dentist's office there. I was just using that story, the whole idea why they want you taking the antibiotics. I completely understand. I had another story though. I got lots of stories. So last time I went to the dentist, they wanted me to use antibiotic for something, and they whatever antibiotic, and I said no, I'm not interested in that. I understand the risks and everything else, but the doctor was like, well. It's like, if you're concerned with this antibiotic, he really wanted me on antibiotics because I understand that, like I say, if you don't follow the American Heart Association guidelines to prevent endocarditis, and you're the dentist that says, no, you don't need antibiotics because you had a knee replacement, and then my wife needs her leg amputated because of that, you're done, right? I mean, I completely understand why we're in this situation where people are protecting themselves. But the story, and maybe it just seemed more powerful to me, but this idea was, he's like, no, I got lots of antibiotics I prescribe you. Like, he thought I had a concern about an antibiotic. He's like, there's lots of different antibiotics I can prescribe you. You know, he didn't, we're not even on the point I'm trying to make is, me and him aren't even on the same wavelength about how we look at bacteria. So, and I don't fault him either. It's just that's where we're at. So, let's see here. I'm going to scroll back up. A lot of good stuff. Let's see. The strep thing we talked about. Objecting. I'll tell you what. I'll put the tinfoil hat on. I'll tell you the most controversial thing that I'm going to tell you this entire semester. And I don't, please, I'm not advising you on anything. I want you to think about something, because this is not a question I can answer. I've tried to look up, I've tried to look up the research, and but I'm going to say it, right? Because not this semester, but I've taught evolutionary biology classes. I teach evolutionary theories and natural selection and all these things in other classes, and that's what we're talking about here. We're talking about this whole idea of a counter running towards zero. That's evolutionary biology. Every time you kill a bacteria that is sensitive to an antibiotic, and you leave one alive that's not, they're going to reproduce. So I think we all understand that point. So from an evolutionary standpoint, I'm going to say that we have to at least consider that there's no standard human. Every human is different. Every pathogen is different. So for two reasons, I think it's actually crazy. That, again, I'm not telling you, next time you get prescribed antibiotics, don't even consider this, but I just want you to think about this, and we'll see where this ends up 5 years from now. Does it make sense in a world where if every one of us had 6 beers, some of us would be passed out, some of us would just be getting started, right? We're different. If all of us were given the same painkiller, they now have genetic testing they can do prior to surgery to see which painkiller you should be given. So if all 3 of us took the same painkiller, works for me, doesn't help you but damages you, and you process it so quickly it doesn't do you any good, right? We're all different. I mean, in every conceivable way. So why is it that everyone that has an infection gets treated, same dose, same duration with antibiotics? So I don't know if there's a better alternative at this point, but the idea that all of us being different need the exact same dose and duration of antibiotics doesn't make a lot of sense. But that's not, now I'm really going into the controversial area. I also don't think it makes sense. I can't believe I'm saying this. Don't take this out of context. I'm recording this whole thing, so you can't. But why? Right? Why? I don't actually, and this is just my educated guesses. I'm looking at the data right now, but I don't actually think it makes sense for all of us to finish our antibiotics either. So let me explain. So if you told me if everyone took 7 days worth of antibiotics and it killed all the pathogens inside of them, I would say that makes a lot of sense. But if someone's given a 7-day prescription for antibiotics, day 3 they feel 100%, 99% better. So enough of the microbes have been killed to turn this back into an infection instead of a disease. And you tell me that in those I don't know what day I was on, 3. So at day 3, you killed 60% of the pathogenic bacteria in this person. They're done. They have an infection. The organism's still there, but their body's going to mop it up. The infection's over, and they're not going to die. They're not going to have this disease anymore. But you killed 60% of the bacteria. If you take that antibiotic for 7 days and you kill 95% of those bacteria, honestly, which is better? Because from an evolutionary standpoint, if I use a chemical and I can't kill 100% of something, the more I kill, the faster it evolves. You have to understand these principles. Evolution generally has worked in history with organisms like us. if my genes are 0.5% better than yours, and which means I'm slightly more likely to survive and or reproduce than you, and you give me, or my population, right, 100 generations, thousands generations, my genes are going to be more common at the end of the 100 generations or 1,000 generations. But see how evolution is usually a really slow process. So it's taken 10,000 years for, look at how many people can tolerate lactose that aren't lactose intolerant. 10,000 years ago, there wasn't a human that could tolerate lactose in adulthood. So it's taken 10,000 years for some of us to be able to drink milk as a 30-year-old. That's how evolution works. Super slow. But we talk about Lysol. We already did. You talk about Lysol or something. You go to that garbage can. I just said this last week. You go to the garbage can in the back of the room. You kill 99.9% of the bacteria that are in there. When we come back next Monday, the garbage can's full again. But every one of them is related to who? The 0.1% that we couldn't kill. So that's why microbes, they evolved in leaps and bounds. So, and again, I'm trying to wrap my head around this. I'm thinking out loud, and whatever you want to say, that's fine, because I absolutely could be wrong. But do you understand what I'm saying? Like, because you're not going to die from whatever infection you had. You're still going to be spewing microbes into the world, like we all do. We don't wash our hands well enough. We sneeze, whatever. You're still going to be spewing microbes into the world. But are you spewing the 40% of microbes that couldn't be killed by 3 days worth of antibiotics, or the 5% of microbes that couldn't be killed by 7 days worth of antibiotics? What do you think about that? Am I completely off base? I'm literally just... these are one of the things that's swimming around in my head. What do you guys think?
I think it probably depends on the person. If the person who was taking it stopped and doesn't have a really great immune system, they're
right.
going to get sicker.
Sure.
And then have to take antibiotics.
Right. And if you're, this is like everything else in this class. It's very nuanced, which is why. See, we're using these archaic diagnostic tools and these archaic guidelines, and we're trying to cram every round hole into these square pegs. So hopefully someday it's much more nuanced, and we know, just like we can now tell when you go to have surgery, by the time you're out, they can tell which painkiller you should be given because of your genetic profile. It could be the same kind of thing. Like looking at the genetics of your immune system might say who goes down which path, right? So who gets maybe some people stronger antibiotics for a shorter period of time, other people maybe less antibiotics for longer periods of time, these kind of things. But no, you're absolutely right. If you have a weak immune system, your infections can reoccur, and not only that, this is kind of the double-edged sword here. A compromised immune system becomes a breeding ground for stronger microbes. So I just think, I'm just trying to challenge the notion that everyone should be treated the same way. So I hope in the future that we have different levels of antibiotics based on the kind of infection you have. But in order to do that, we have to have better diagnostics. We can't, if we want to get rid of the abuse of antibiotics, that at this point that would involve blood work to see if you even have a bacterial infection, culturing the organism. So 3 or 4 days from now, we'll finally be ready to get to work, helping someone get better, and that's unacceptable. So we have to. Hopefully we have. You can map a human genome in 5 hours now. They can do it at UNMC. So in the future, I'm hoping it's okay. Well, here's your genetic profile. Here's the organism you're dealing with. What should we do? So I don't know. This is probably the thing that I will say the entire semester with the least evidence to back it up, and that's why I'm being very clear about that fact, because I want to know the answer to this. Just like I want to know, I keep bringing it up, and I have been researching it. I want to know why we tell you to flame the necks of those tubes, because I can't find any data to say it does anything. Well, same thing here. If you can't prove to me, and I'll find some. I've been reading some interesting, evidence-based blog posts about this. I'm not the first person that had this thought. But I'll see if I can find the evidence one way or the other. If you find some, please share with me, and I'll share it with the group. I'm just asking a question. I'm just being curious here. But I just have always wondered that. Even when I had the most serious strep throat infections I've ever had. Because strep, so somebody mentioned something about biofilm organisms with UTIs and stuff. I have strep, I was super, super sick. 2 days later, I'm fine. So Does beating that strep infection back with 8 more days of antibiotics do any good? It depends, but you also let's add another layer of complexity here. The strep's hiding under a biofilm on my tonsils. That's why I haven't had strep once, because my tonsils are removed. The bacteria hiding in that biofilm, 1,000 times less likely to die from the amoxicillin that they give me. So now I'm just doing. I beat off. Well, what's that word? I beat back. I killed. I don't beat off bacteria, by the way. But sorry, that was weird. This is why I don't like to record things. I'm recording it in case somebody couldn't hear it earlier during class. We've beat back the planktonic cells, the ones that aren't hiding in the biofilm. All evidence of infection's gone. Is that bacteria gone? No. That's where recurring UTIs, recurring strep infections come from. Does taking antibiotics for 6 more days really increase the odds that I'm going to kill off those bacteria that are hiding under biofilm? I don't know. If you find, please, you guys are super smart. Find some evidence one way or the other, and let's discuss this. Whatever you share with me, I'll share with everybody if you allow that. So, go ahead.
Honestly, you can't get rid of all of them, no matter what you take.
If they're hiding under a biofilm, which 70% of infections, the CDC says this, it's probably higher, but the last data I found from the CDC says 70% of infections are caused by biofilm-forming organisms. Which means that, you can wipe out the ones that aren't hiding, but you can't eliminate them. So, SIBO. So just another argument on why my thought process has gone this way. I probably told this once already, but there's a case report of treatment of SIBO, small intestinal bacterial overgrowth, 9 months straight of antibiotics. Now, luckily with SIBO, they do use antibiotics that aren't actually absorbed because they're trying to kill off an infection in your gut. So they don't do near as much collateral damage as ones that would work their way into your bloodstream. But 9 months of antibiotics, they're feeling perfectly fine. They get off the antibiotics, 2 weeks later, raging SIBO infection. Risk reward. What was the reward of 9 months of antibiotics then? I don't know. It wasn't very big, right? So what's the risk? Because was this drug only killing the overgrowth of bad bacteria in the small intestine? Or was it damaging good bacteria and also damaging bacteria in the colon? This is why we have to reconsider everything. So I can't answer these questions. Nobody can. We're years ahead of where the discussion's going to be, I think. So, all right. So my view on vaccinations, we'll have a vaccination discussion. I'll do the same thing. I'll kind of go through the whole personal thing. But that's chapter 18. We got a ways to worry about that. So, I'm just looking here. You guys, so much good stuff, guys. This is exactly what I wanted to happen. So, what do we got? We got 6 minutes. So, chronic UTI stuff. Yeah. So I don't know what to do with that information. We've got this. We know then if we're going to deal with the chronic UTI, because you guys work in nursing homes, you see it all the time. Ezra doesn't get a UTI every month. Ezra has a UTI that reaches an infectious dose kind of level once a month. The antibiotics fight off those. Exactly what we just said with strep. The antibiotics fight off those cells that are out and about and causing problems. The rest are hiding under the biofilm, and they'll be back in a month when the numbers reach a point. That's that quorum sensing idea. You got with Bonnie Bassler's talk, which I think is probably next week actually, where their bacteria release chemicals in the environment, kind of like maybe you'd consider them our pheromones. They're counters. And when they reach a certain level, that's when they become pathogenic. So the number reaches the pathogenic level. We fight off enough of them to get the symptoms to go away. Comes back in a month. So, but the question is, what do we do with this information? We don't know. We don't have good biofilm disruptors yet for the urinary tract. The biofilm disruptors we do have, sugar-free gum. Now, we go to Amazon and we buy xylitol gum because, again, I'm kind of anal about I don't want the kids to be exposed to artificial sweeteners. Not saying that they're bad, for sure. But I don't know. And if I don't know, I don't want my kids to be exposed to them. Will I have a Coke Zero every once in a while? Sure. I'm gone. I'm a goner, right? So I'm 40. It's a downhill slide. So with the kids, with developing brains, we've just made that decision. So we do, so rather than regular sugar-free gum, we use the xylitol gum. But xylitol, it's a sugar alcohol, and it is a biofilm disruptor. It disrupts plaque is a biofilm. That's why sugar-free gum it actually is a biofilm disruptor. It disrupts the biofilm in your mouth called plaque. Another one, if you have sinus issues, so people will talk about some sinus stuff on here. What we use there for a biofilm disruptor is there's two studies have shown, and you guys, and if you want me to find this for you, I can. But 2 studies have shown that a mixture of 1 drop of Johnson's baby shampoo, 60 drops of water. Actually, you can use that with nasal irrigation. Now, with nasal irrigation, I recommend using either salt water or distilled water, not tap water, because of brain-eating amoeba. It's only happened in 3 Americans, but 3 Americans have died from a brain-eating amoeba infection from tap water. But we'll cover that with the parasite stuff later. I don't use that. If you don't want to be mixing Johnson's, but there were 2 studies that showed that work. Xlear, it's called Xlear on Amazon. It's a xylitol biofilm disruptor you can use in your nose. We really love it, but they don't have one. Like I don't know how to teach the urinary tract how to chew gum. So like at this point, we don't have good biofilm disruptors there, but we will. So I don't know. Like I said, I can highlight problems at this point that we don't have solutions for. So if you can come up with a biofilm disruptor that can obliterate the biofilms of the female urinary tract, all urinary tracts, but especially the female urinary tract, that's going to be a really big deal. This needs to be researched. As far as like irrigation, these kind of things, I don't know. No one's taking this seriously enough yet, and that's why no one. We just right now we're worried about superbugs, and we should be, but. So I don't know if it's even much on people's radar at this point, but somebody's going to figure it out, I hope.
Probably because the urinary tract infections are usually like us.
They're common, but yeah, they're not generally not fatal, and they're What I found in this country, I'm not going to get political, but if something affects middle-aged white men, it gets addressed a lot. It gets addressed a lot faster. So, and that's just true. Literally that's research based, looking at like heart disease. Like almost all the research on heart disease has been done on middle-aged white men. That's just reality. I'm not going political here. It's just look at the studies. So, all right. I'm gonna see if I can copy and paste. I'll copy and paste the group chat, and if I didn't get to get to what because we're going to be done here in 2 minutes. If I didn't get to you, I'll see if I can answer these last few questions here. So testing, I already sent the information out. If you're here in Sioux City, the testing center is first come, first served. They're open 8 to 5, Monday through Friday. So you guys have till Friday at 5. Denison and Cherokee, just because they're undermanned campuses, don't just show up. Please, I told them that I would promise to tell you, make an appointment. And if you're going to come Friday afternoon, I don't know when they close, especially Fridays during the summer. I'm not sure if they're open till 5. So check the hours of the Denison and Cherokee campuses, and make sure you don't all show up Friday at 3, because that might be a problem. So if you know what's on the videos and you know what's on your test review, you're set. This is what I want our discussion to be about. I do not want to rehash what an axial filament is like we were doing last week because everything got thrown asunder. That content's already covered. So I hope these are the types of discussions we can have. And we'll have there's a couple things on here about vaccines. We will have a whole day where we talk about vaccines, and any opinion is valid and is welcome that day. And let's just have it out in a kind way. So okay, I'll see you guys in 10 minutes. I'll see everyone else on Thursday. See if I can copy and paste this.
I'm ready for a nap.
I'm always ready for a nap. Oh, this is cool. I think I might be able to just copy and paste the whole thing from the beginning. Yeah. Like when? This morning?
Yeah.
I know. I was in here. I was in here with the IT guy all morning trying to make sure this worked. But we can talk as soon as I get this pasted. Oh, well, I guess that's already been addressed.
Yeah, we thought the exam would be on, like, our discussion days. So it kind of conflicts with their work schedules.
Oh, well, and they have to be proctored, though, and the testing centers aren't open on Saturday and Sunday.
How long is
It was supposed to just be today. We were going to just have it today.
Yeah.
So it's our... how long is it?
Yeah.
I always tell them it's a 90-minute time limit, but it doesn't take that long. And no, I'd say 98% of students have it done by in an hour. It's 50 questions. This won't work. But you have, so you're saying there's no time all week you guys can be here?
That's what I'm trying to do. But I just texted my boss.
Sure.
I should be able to flip-flop something. Not as hard for me.
Yeah, honestly, I'm trying to do everyone a favor because we could do it during class, but we only have 16 hours together. I don't want to spend 4 of them taking back 4 notes. Yeah, if you can't get something worked out, just email me and we'll figure something out. So, because you can use, I mean, I allow you can use other proctors, like you do in an online class. Your boss, your boss could even do it or something like that. Yeah, public libraries. Yeah, there are lots of places that are acceptable for proctor locations. So if you can think of something of like if the library stays open later, or your boss will let you sit there after your shift or something, just let me know and give me their contact information, and I can send them a proctor form.
Okay,
Yeah.
thank you.
Yep. Yeah, you too. I mean, if that's, I mean, it doesn't have to be at this testing site. I have already sent information for 2 people because some people drive in. If you can, if you can find a better place to test, I'm all ears. See you later. Or wait, see you in a few minutes.